Community House Calls program of case managers and cultural mediators, or CCMs, has been in place since 1994 at Harborview Medical Center, a Level 1 trauma center in Seattle. Here, a talented team of 8 CCMs focuses on education, interpretation, case management, cultural mediation, and chronic diseases. In its design, the emphasis on health education for new immigrant communities has been sustained, but a greater emphasis is placed on retrieving expertise from the community to support the linguistic and culturally appropriate care of patients in this large urban trauma center. Physicians and nurses are able to visit their patients at home. The community has a voice within the healthcare institution to express their cultural preferences, and the medical center and refugee communities call on one another, thus community house calls. Over time, as expertise evolved, the program grew in depth and breadth and now includes specialization in chronic disease management, cancer care, palliative care, and patient navigation for a wide range of diagnoses. The best way to appreciate the breadth and depth of this remarkable program is to see it in action in representative cases. The credibility of CCMs in their communities derives from their long-standing reputations as navigators in the hospital for patients and family. Through word of mouth, they become known as capable and experienced interpreters and advocates within the hospital and health system. Each CCM participates in community organization and is on community health boards. In this role, they explain the culture of American medicine, its peculiar practices and common diagnoses, and when they do, people know this is information born of years of experience. They may discuss health insurance, healthy diets, child protection services, asthma management, cancer screening, or end-of-life planning. Each of these may be new and unfamiliar concepts in the immigrant culture. The Ethiopian community has been well established in Seattle for decades. Here, for example, the Ethiopian CCM plays a supporting role in her health fair. Similarly, the Vietnamese seniors meet weekly, and the Vietnamese CCM is a central organizing force. She is master of ceremonies, cheerleader, and often arranges speakers and sets the agenda for key meetings. Dietary discipline is the cornerstone of diabetes management, and diet is one of the first, most intimate, and sometimes the only thing immigrant communities can reproduce from home. Their way of cooking and eating is central to identity, comfort, and carrying forward their culture. Therefore, it takes someone who understands how people shop, cook, and eat to help them manage their diabetes within their social and cultural contexts. Sometimes this may mean how they manage on the streets if they're homeless. All of the CCMs find themselves engaged in diabetes care, but in recent years, 2 CCMs specialize primarily in diabetes care among the poorly controlled diabetics of their large communities. Jorge Gomez lives in and out of shelters and on the streets of downtown Seattle. The diabetes navigator meets with him routinely whenever she can, wherever she can, to find him and help him review his control and to teach. She will then interpret for him with his primary care provider to review their progress.
Cuando está 115 así que bajo a ver 120, más o menos me siento bien.
Well, when it's 115, 120, I feel fine.
Yeah, good.
Y cuando como y cuando subo así a 200 también me siento bien también. Pero
After an amputation, Mohammed was placed in a nursing home for recovery and rehabilitation. His diabetes navigator visits him there to encourage him and to teach and review his progress.
So my patient Mohammed is a 62-year Somali male, originally from Somalia and Somali speaking, and he's a father and has 8 children. His wife right now is in Ethiopia, but he has 4 kids with him here in Seattle. His wife is in a refugee camp. He is diabetic, and he also has coronary artery disease. He has hypertension, hyperlipidemia, and diabetes. He's also an amputee. So when I was working with him to help him with his diabetes, and the main challenges was when I talked to him about medication and exercise, because he's an amputee, it's hard to do the exercise, but he was trying. And the other thing is the food. He would like to eat as a Somali man, it was hard for him. He didn't know how to cook. So what he would do is buy his food from the restaurants and trying to explain to him about the portion. And so because he didn't have any choice, he would eat mainly rice, a lot of carbs, a lot of tea that has a lot of sugar and spices.
Continuity interpretation and navigation of chronically ill patients through the maze of doctors and ancillary services that comprise contemporary healthcare is central to what the CCMs do daily. Through house calls, the hospital calls on the individual in their home or community setting and explains the order of events and the complex series of studies, myriad medications, and order of visits that comprise their care. Anab here explains diabetes diagnosis and its management at the home of her patient. Later, when she returns to the hospital to chart, she reports to nursing staff in the clinic to arrange for needed supports.
Hard time standing for prolonged periods of time.
Yeah.
Do you happen to have her H number?
Yes, her last name is Ibrahim, Ibrahim. First name is Zamzam, ZMZM.
Okay. Oh yeah. Oh yeah, she's got gait instability. Okay.
Another thing she wants is I think that means...
But the heart of the program occurs when the CCM, having assessed the social setting of their client, can provide essential details to the provider which the patient may struggle to explain or may not realize are relevant. For example, a large family may have multiple illnesses, social and legal challenges, and financial constraints that impact their ability to travel to clinic, purchase medications, or manage competing demands. A busy clinician may not have the time or presence of mind to know these are pertinent to their patient's care, but once known can be factored into treatment options. Often cultural history or attitudes are relevant to patient care, and the CCM can give voice to the past where it's relevant in the present. Imprisonment, torture, years in camps, long migrations, fear, and deeply held convictions impact patient behavior, and it takes an experienced guide to bring these to light.
Vì môi mò chuôn nó vì màu quỳ nó người kỳ buộc mai cái hóm thà về tròn rót ai biết cái vô với tàu sắp ta mà phép cái chỗ mà vĩnh thì thà có mọi lư mót á ta lư mót ở tu khẩu trầu nhưng cái đó nhưng mình bờ muối ấy là nhưng ta bị thổi theo chết ta lư sâu thọc đôi mình lư đào bị khởi nhưng ta làm tiếc nhưng mà hiện trộn tiếc đấy nhưng phải là nhưng mà chạm nhưng tiếc làm xã kho ai máu cái mê thỉnh cái bị chung tới cái thà bom ôn của mọi thơ ta mà mỗi lần tới cái bia thôi mà lên mưa tấm óp phải chứ hoặc mưa nhẹ nó ở bên nó ở sự khâm đôi khi làm bia tốt có sự khâm thà dương slap đấy ngày nào mỗi dương slap đấy hay ở đâu ní bên coi tự nhiên nó còn mà toàn bàn tự nhiên chiêm nó trên là cười ta mà thầy về bà bà cho hờ mà hay xong doctor tao đi sập mai chụp bom phôn mà đón doctor ta phải tầm đo lên tới màu bình bàn rồi tao hay mà lấy.
Among Harborview's many strengths are its trauma, vascular, orthopedic, and neurosurgical services. But Latinx patients already feeling vulnerable due to cultural difference, linguistic barriers, and political turmoil can feel distrustful of an intimidating setting like surgery. Now, a CCM working closely with the surgical services meets patients upstream to inform them, consent, reassure, and facilitate their trust in the surgeon and the operation. Later, post-operative instructions and wound management are made comprehensible, and the patients monitored. This continuity helps to prevent wound infections and unnecessary readmissions and revisions. The emergency department and intensive care units are central to the daily work of large urban trauma centers like Harborview. The medicine in these settings is fast-paced and complicated, and life and death issues are particularly confusing to families unfamiliar with end-of-life decision-making. The House Calls program routinely finds itself mediating between families and staff. Consider this example. On a daily basis, the CCMs check the hospital census for patients admitted to the ICU overnight in their respective language groups, and then visit them to check in with their families. On one such occasion, a 41-year-old Mexican immigrant woman, a successful business owner, whose husband also had a landscaping business, was admitted through the ER after having been stabbed in the neck by her schizophrenic son. He had stopped taking his antipsychotics and was agitated by recreational drug use. He severed her spinal cord and carotid artery and caused massive blood loss. Jose found her in the ICU on a ventilator, comatose and immobile, a quadriplegic, and unresponsive from an anoxic brain injury. The ICU team had twice established that she was brain dead. They felt, therefore, the humane thing to do was to begin a discussion of the withdrawal of life support. Her husband was at bedside, devastated and numb. The family was not at all ready. They had not adjusted to the fact that their matriarch, who the day before was managing an active business, was now comatose and brain dead. They were in shock, confused, scared, unrealistic and powerless. The family saw reflexive movement and thought it was purposeful. They had a friend who'd awakened from a coma and thought this might happen for them. They also wanted her older sister, who had raised her, to come from Mexico to help make any decisions about ending her life. They were unwilling, resistant, and afraid. On the other hand, the ICU team was stressed and busy, and this was a brain-dead case being tormented by blood draws, medications, and intubation. They were impatient with what they considered cruel and inhumane treatment of a woman in a vegetative state when it was futile. In the ICU, decisions need to be made quickly because things change quickly, and the care is very expensive. There is often tension between medical teams and families. Jose had to step in between both parties.
I asked the medical team to meet with the family in smaller groups without students and residents and arrange for continuity between attendings. Since they were people of faith, I asked the team to allow a chaplain to open the conversation with prayer. I worked with a Mexican consulate to expedite a visa for the missing sister. I asked the attending to demonstrate for the husband that her movements were reflexive and not an effort to communicate. The family and team began to calm down and work together. She died within 48 hours before her sister could come, but with the family at bedside.
Supervised by a registered nurse who provides guidance and assists with their most difficult cases, the program is nested within interpreter services, with administrative oversight by leadership intimately familiar with linguistic and cultural challenges in healthcare. As a result, the program provides seamless communication from the community to the executive leadership within the medical center. Through the years, it's been adapted and reproduced across the country and recognized as a model that works. It has received numerous awards from the American Pediatric Association, the American Medical Association, the American Hospital Association, and the U.S. Congressional Black Caucus and Office of Minority Health with the Booker T. Washington Award. The breadth and depth of community health calls is remarkable. From community-based prevention to hospital-based palliation, the program coordinates the care of complex patients in a number of Seattle's larger immigrant communities. The CCMs explain to clinicians the cultural and the current social and financial constraints of patients. They also know medical culture and what services are responsible for what issues, who makes key decisions, and the order of complex workups. They coordinate between sister hospitals like the university and the cancer center, or with schools, consulates, and the housing authority. They support physicians and surgeons in their care and support immigrant families through the compounded complexity of their lives with a grave illness. They ensure that both patients and physicians do not feel rushed or bullied, but feel heard and understood, all within the context of a trusting relationship.